This is a 72-year-old woman who has symptomatic atrial septal defect of the secundum variety that has been sized anywhere in the low teens to the mid-20s by a variety of imaging modalities. Today we're going to close the defect. We're going to use image guidance that's both traditional fluoroscopy but also using echocardiography, specifically real-time 3D TE with its accompanying X-plane, two simultaneous ultrasound perspectives. And that will be performed by Dr. Robert Quaife of our Advanced Imaging Group.
Peggy PA gas.
As you can see, we have things set up here so everyone can see the images. And so we've got now the X-plane, two different ultrasound views of the atrial septal defect, looking at the color flow. And we're looking for several things. Number one, the quality of the rim tissue. Number two, the dimensions in each 2D image. And then we'll be further looking at the shape of the atrial septal defect using both X-plane and 3D real-time TEE. So here we see a nice thin septum primum, the inferior rim, and a thick septum secundum. So now we see a beautiful 3D TE picture of the secundum atrial septal defect, and so SVC's at the top. So one of the things we've realized is that it's nice to present the three-dimensional echo views in a perspective that gives the interventionalist some orientation. So this is very similar to like a PA fluoroscopy view where we have the SVC in the superior, we have the IVC below, and there's the atrial septal defect. So we're looking now on the right atrial side, and could you turn it around? Let's look at the left atrial side of the defect. So there it is from the left side. So notice how we've reconfigured the room for a structural heart disease case with general anesthesia with 3D TE guidance. We've moved the gantry 180 degrees so it's out of the way of the echo team and out of the way of the anesthesia team. And so they have complete access to the patient's left side. So now you see the nice echo image, 3D, with the Omplot's extra stiff wire across it. Now you see the balloon catheter across the atrial septal defect. And now I'm going to slowly inflate. So we're watching both fluoroscopy and the ultrasound. And see right now I'd say advance the balloon catheter a little more. So we're trying to center. See, that's pretty centered right there. A little more. Yeah, let's have X-plane in color. I've got a little waste. So I think we're going to stop there and we're going to see if there's any color flow. The color gone? Okay. And a quick cine. So we could either do X-ray, a quantification of the waste, or ultrasound. It looks like it's really going to be in the mid-teens. It didn't enlarge as much as we thought it might. So fluoro again. It just looks like it's might have. Yeah, right there is a nice waist. So it's an 18 or a 20 device. So I think with the floppy septum, this is basically an 18 measurement. We'll go with the 20. 20 ASO device, please. And delivery catheter. So we've got it on. We make sure that it's threaded correctly. And so we have it all attached. So we've got the device up to the end of the delivery catheter, and so we're going to expose the left atrial disc and allow it to come. Now you see the device in the 3D image, and you're going to pull everything back, just watching the 3D image, okay? Stay right there, Rob. Keep coming. Keep coming. And stop there. So notice how it's nicely aligned. This looks great. Fluoro for a second. Fluoro looks fine. So let's give Rob a little opportunity to look at it. And so now we go to X-plane. So bring everything down a little more. Pull back a little more, everything. And stop there. Okay, so we've got good alignment in this view. We're going to deploy the center and the right atrial disc. There, it looks very good. You've got good capture on the echo image. And now we turn to ultrasound. So we see a beautiful capture of the superior rim on the left side of the X-plane. Good capture of the aortic rim on the right side of the right image. The posterior rim on the right image, left side. And on the left image, we're looking for the inferior rim. Notice how echogenic the cable is. And notice how it really tilts the device. So once we release, it's going to go flat. So now we'll go into 3D to take a look at the device and the capture. Yep, so there's a nice thin septum primum within. So with the 3D TEE, using the X-plane and the real-time 3D, we can much more effectively and efficiently deploy these devices by first focusing in on the alignment of the left atrial disc to the secundum atrial septal defect. If we just had one 2D ultrasound image, it might look good in one image, but in another perspective, it may be way off, and then we try deploying it and we miss the rim capture. So this really makes the process of ASD closure much more straightforward. In addition to the inherently better sizing of a defect and understanding the anatomy you get from the 3D imaging. So Dr. Quaife is now focusing in on number one, do we have rim capture? Number two, do we have any residual leaks? And number three, and very importantly, where are the edges of the left atrial disc and the right atrial disc? Are they pressing into any contiguous structures that would make us worry about a potential risk of erosion? Are they interfering with any adjacent structures like the AV valves and the pulmonary veins? So we just sit back here and all look at the images as he interrogates the device anatomy interaction. The device looks nice and flat already, even with the cable attached. So the closure really takes three steps. The first is the pure mechanical of putting the cork in the bottle. The second is the platelet thrombus within the discs. And then thirdly is the slower process of device endothelialization, which we assume takes place within 6 months because that's the duration of our antiplatelet therapy. But in some patients, it may be a longer duration process that we have really no way of monitoring because we're really talking about a single layer of tissue growing over the device. And really we're just spending some extra time here to be sure of our result before we release. So this is just great seeing these large ultrasound images. It really allows us to understand, as well as the echocardiographer, of whether we've got the correct device placement, whether we chose the right size, whether we see any interference with contiguous structures. And you can see he's looking at it from, here's a nice view of the left atrial disc, and then he can rotate and show us the right atrial disc, and you see that bright line coming in, that's the cable. So now we go through the same process of using predominantly ultrasound with a little fluoroscopy to make sure we've got a nice, flat, well-opposed device that's doing what we want it to do, that is closing the atrial septal defect. See how nice and flat that looks? And again, the efficiency of the X-plane is that you can see two different ultrasound perspectives at the same time. So what we wanted to demonstrate with this case is the integration of ultrasound into the procedure room to guide structural heart disease interventions. And it's both an integration of technology as well as an integration of another team to allow us to do these efficient structural heart disease interventions. And the three-dimensional aspect of the imaging really helps in terms of understanding the anatomy of the atrial septal defect, but also during the actual deployment of the devices in terms of the alignment in 3D space of the left atrial disc, and then to do a quick, efficient interrogation of whether we have rim capture, whether we have residual leaks, whether we have any issue with the device interfering with contiguous structure. So the additional time to set up the team with anesthesia and the echo team, to me, is often worth it in terms of getting a great result and having confidence. The value increases even more proportionally as we get larger and larger ASDs, where we have 2 ASDs. The more complexity, the more this approach makes sense. So the integration of X-ray and ultrasound is only in its beginning. We'll hopefully see in the next couple of years a lot more tools that will come along that will help us.